We are live.
Good evening. Welcome to our webinar, Walk-in Retina Patient. This is the second in our series of Walk-in Retina Patient webinars this season. And we bring to you very interesting clinical situations today with our eminent faculty. Chairman of the session would be Dr. Harvansh Lal, who is the President of All India Ophthalmological Society. It will be moderated by Dr. Manoj Mathur and Dr. Ganesh Pillai, who is the Medical Director and Consultant of ASG Eye Hospital, Bhopal. And we have discussants, Dr. Lalit Verma, who is the Director of Retina Services, Center for Sight, New Delhi, Dr. Dinesh Talwar, again, one of the directors in Vitro Retina and Uvea Services, Center for Sight, New Delhi, Dr. Prashant Bawankule, who is the Chairman of ARC, AIOS, and also Chairman of Sarakshi Eye Hospital, Nagpur, Srinivas Joshi from Joshi Eye Institute, Hubli, member of ARC, Dr. Piyush Bansal from Birla Memorial Eye Hospital and member of Scientific Committee AIOS, and Dr. Tinku Bali from ARC AIOS and Gangaram Hospital, New Delhi. Our speakers are diverse. They are from all parts of the country. Starting off will be Dr. Hiteshi Shah, who is Vitro Retina Surgeon of KEM Hospital, Mumbai. And she'll be speaking on interpretation of macular edema on OCT and biomarkers. Following her would be Dr. Divya Alex from Ahalya Eye Hospital, Eye Foundation Hospital, Kochi, who will be speaking on walking in patient with diabetic macular edema. The third speaker is Dr. C.K. Nagesha, who is a consultant in Department of Vitro Retina, Narayan Netralaya, Bangalore, and he'll speak about hurdles in diabetic macular edema management, a case-based discussion. Then we have a very interesting talk on walk-in patient with peripheral exudative hemorrhagic chorioretinopathy, which is a poorly understood topic as far as general ophthalmologists are concerned. He's the Medical Director, Retina and Vitreous Services, Shroff Eye Center, New Delhi. And the last talk is by Dr. Diksha Katoch on a very, again, an interesting topic on anti-VEGF in retinopathy of prematurity. She's an associate professor from the Advanced Eye Center, PGI, Chandigarh. So I hand you over to Ganesh for rest of the proceedings.
Thank you so much, sir, for all the kind introductions that you have given. Without wasting much time, I think we can move on to our first presentation by Dr. Hiteshi Shah. It's again a very important topic of interpretation of macular edema on OCT and its biomarkers. Dr. Hiteshi Shah is a Vitro Retina surgeon at KEM Hospital, Mumbai. Can you share your presentation, ma'am?
Yes, sir. Can you see my slide?
Yes, yes.
Yeah.
Good evening, everyone. Just a small correction. My name is Dr. Hiteshi Jain. I think they put it wrongly on the flyer. Hiteshi Jain, I'm working at KEM Hospital as a VR surgeon. And it is my great pleasure to be a part of this in front of the eminent faculty from all over India. So I'll be talking about OCT biomarkers in DME and their interpretation and relevance in the current world. Yeah. So just a little bit about the pathophysiology of diabetic macular edema specifically. We all know that it is because of the loss of pericytes surrounding the capillary endothelial cells, which causes the distension of the capillary wall and therefore the breakdown of the blood-retinal barrier. There's also an inflammatory process going on in the eyes of diabetics, in which there is increase in VEGF, matrix metalloproteinases, interleukins, leading to increase in the oxidative stress, further leading to breakdown of the BRB. All these things cause changes like microaneurysms, hemorrhages, retinal edema, hard exudates, which we commonly see in the eyes of diabetics. So the classification, the clinical classification has changed over a period of time. ETDRS was the first to give us a significant classification in 1985, which defined clinically significant macular edema, which all of us know very well. There are three definitions which state that retinal thickening at or within 500 microns of the center of the macula, or if there are hard exudates along with retinal thickening at or within 500 microns of the center of the macula, or if there's retinal thickening of one disc area, any part of which is within one disc diameter of the center of the macula. Then in 2018, the International Council of Ophthalmology gave us a much simpler classification of DME, which stated that DME could be center involved or non-center involved, in which they said that the central subfield zone is 1 mm in diameter, the center of which is the fovea, and any retinal thickening in this diameter is called center involved DME. Any thickening which is away from this is non-center involved DME, and this helps us in treating the patient or deciding the form of treatment that we are going to use. With the advent of OCT, it became much simpler to objectively measure the central subfield thickness. So drcr.net came up with the definition of central subfield thickness, which is the average of retinal thickness values in the central 1 mm zone. So in an OCT, there is an ETDRS grid, which has 3 circles. The central circle is 1 mm in diameter, which is the central subfield zone. The second circle is 3 mm in diameter, and the last circle is 6 mm in diameter. So anything in the central circle is known as center involving DME. DRCR also gave us definitions for increase in CST according to the particular machine that we're using, specifically for Heidelberg and Zeiss. Unfortunately, these values are not interchangeable between different machines. So it is very specific to a single machine. Before talking about the OCT biomarkers, I would like to talk about interpreting a normal OCT, in which we must look at 5 parameters, which is the visual interface, the visual retinal interface, the inner and outer retinal layers, and the RP-Brooks complex, in which the outer retinal layers, the most important outer retinal layers that we can easily make out are the ELM and the ISOS junction. So coming to the OCT biomarkers, the most commonly and widely understood is the central subfield thickness, which again is the average thickness of the macula in the central 1 mm ETDRS grid. We must understand that it is a quantitative OCT measure, but it is not a substitute for visual acuity, and it is not prognostic nor predictive of the final treatment outcome. So one more important thing that DRCR told us, that lack of improvement. What does lack of improvement after treatment mean? If there is no increase in the visual acuity of more than 5 letters, or that is approximately 1 line on Snellen's chart, or if we look at the central macular thickness or CST, if there is no decrease of more than 10%, then we can call it as a lack of improvement. Coming to the type of edemas, the spongiform and cystoid macular edema. Spongiform is because of diffuse capillary leakage, and it is due to accumulation of fluid in mainly in the ONL and OPL. Further degenerative processes can also cause cyst formation. These smaller cysts can coalesce and form larger cysts. So larger cysts are a sign of chronicity. Further breakdown of the outer blood retinal barrier can cause accumulation of fluid in the subretinal layer, which is also known as neurosensory detachment. The relevance of this particular biomarker is that it is a good predictor of therapy, and elimination of these, that is subretinal fluid and intraretinal cystic spaces, are an important end goal of treatment for us. The next thing that we must look at are the bridging retinal processes. These are nothing but residual neuronal processes which connect the inner and outer retina. They are Muller cells, believed to be Muller cells, which relay visual impulses from the inner to the outer retina. The lack of these indicate chronicity, and therefore are an indicator of poor visual prognosis and resistance to therapy. Next in line are hyperreflective foci or dots and hard exudates. These are not the same. Hyperreflective dots are much smaller. They are less than 30 microns in diameter. They are less reflective as compared to hard exudates. They do not have backshadowing. They're usually seen in the inner retina. They can migrate to the outer retina, which is not a good sign because they lead to disruption of photoreceptor cells. The relevance of these is that post-therapy, they can be absorbed, they can permanently form a cholesterol crystal, which is very notorious, and they can migrate centripetally to the fovea and appear as if they have increased if there is a sudden decrease in macular edema. There have been studies which show that higher number of hyperreflective foci may respond better to initial steroid therapy. Next comes the disorganization of retinal inner layers. These are damaged inner retinal cells, and again, they indicate a disruption in the normal pathway of light from the inner retina, from the ganglion cells to the photoreceptors. We can see in the upper two images that we can easily make out the inner retinal layers. We can demarcate them easily, whereas in the lower two images, the inner retinal layers are not easily demarcated. Again, these are a sign of poor prognosis, resistance to treatment, and chronicity. Next comes the vitreomacular interface anomalies, which mainly consist of epiretinal membrane, vitreomacular adhesion, and vitreomacular traction. These are all due to anomalous PVD, which means that the presence of a complete PVD, according to studies, it is good prognostically, mainly because it increases transvitreal oxygenation, it decreases hyocyte proliferation on the surface of the ileum, and it also decreases the growth factors in the premacular hyaloid. So coming to the epiretinal membrane, it is a hyperreflective membranous structure at the vitreomacular interface. The most common cause of epiretinal membrane is PVD, but diabetes comes third in the cause of the secondary epiretinal membranes. Over here in this picture, you can see a thick epiretinal membrane, which is causing traction to the underlying retina. There is disorganization of inner retinal layers. There is some traction which appears as cystic spaces. So this kind of edema may not respond very well to intravitreal drugs, may respond better to vitrectomy and membrane peeling. Next are vitreomacular adhesion and vitreomacular traction. As the name suggests, VMA is just the adhesion of an anomalous PVD to the macula. It does not cause underlying disruption of the retinal structure. Whereas in VMT, we can see that this traction is causing cystic formation of cystoid spaces, which may be relieved by vitrectomy and ileum peeling. Another thing that we must look at is the ellipsoid zone continuity, and the disruption of ellipsoid zone denotes a loss of photoreceptor cells, again, a very poor prognostic factor. These are a few examples of, this was a patient with diabetic macular center involving diabetic macular edema. We can see a neurosensory detachment here with hard exudates and hyperreflective foci. This patient was injected with intravitreal triamcinolone. The patient responded well at 1 month. There was complete resolution of the neurosensory detachment, and the patient's vision improved to 6/12 parts. This is the pre-injection image of a patient with moderate NPDR with center involving diabetic macular edema. He was injected with anti-VEGF drug, and the edema resolved at 1 month. This is a patient with vitreomacular traction. Vitrectomy with ileum peeling was performed in this patient, and we can see the result at 2 months. So the take-home message for everybody would be to assess an OCT properly, not just look at a couple of parameters, but also look at the risk factors, which may indicate that this is a patient with poor visual prognosis, so that we don't end up over-treating the patient. So risk factors like large cysts with loss of bridging processes, hyperreflective dots, ellipsoid zone discontinuity, VMI disorders, and DRIL, they suggest poor prognosis. Then there are markers which predict visual gain and markers which predict response to a particular therapy. So markers which predict the visual gain are loss of ISOS junction and ellipsoid zone reflectivity. The markers which predict response to better response to steroid would be a neurosensory detachment or hyperreflective foci, and better response to vitrectomy would be markers like ERM and vitreomacular traction. Thank you.
Thank you, Dr. Hiteshi, for nicely touching upon the important points of OCT biomarkers. I'd like to get comments from Dr. Srinivas Joshi. Sir, he has to go somewhere.
Thank you, Dr. Ganesh. Thank you, Santosh sir, for this wonderful webinar. I think Dr. Hiteshi has covered most of it. So just for the general ophthalmologist, I think OCT biomarkers are now coming to our way when we want to choose the difference between the anti-VEGF versus the steroids. And what she said about one point I would like to touch upon is apart from the hyperreflective foci very tall cystoid spaces. The other thing is the bridging retinal processes. So especially these are the tissues that represent the residual neural elements which connect the outer and the inner retina, and they thus help in transmitting the visual impulses from the inner retinal layers to the optic nerve and then to the brain. So I think if the BRP is present, then that means that is a good sign. But these kind of cystoid spaces, they try to coalesce together and form a very large cystoid spaces. That is what is the poor prognosis in these kind of cases. But definitely for me in my practice, in the clinical point of view, definitely it's going to help between choosing which kind of anti-VEGF I want to start. If there is already a hyperreflective foci, very tall cystoid spaces, and a majority of these biomarkers are present, then I immediately don't switch to anti-VEGF. I switch to intravitreal steroid first, especially the dexamethasone implant. And then if it's a naive case with just a neurosensory detachment with the intraretinal fluid, with not of much other biomarkers, then my first choice would be to go in for the anti-VEGF injections. And then if they don't respond for it, then I probably would go in for the intravitreal steroids.
Hello.
Yeah,
Yes, sir.
Lalit sir, your
I-
comment, sir.
Yeah. No, excellent talk. I enjoyed most of it. But you see, today
Thank you,
OCT should not just be, people should not interpret just as edema plus or edema minus. That's what we keep saying sometimes in our clinical practice, that practitioners will write edema plus, hence anti-VEGF. Edema, okay. So like madam was telling about that you should interpret OCT at least in 3 lines, What is happening at interface, what is happening to inner retina, and what is happening to outer retina. So that I think all of us should form a habit. We should not like radiologists, infarcts in CT scan or that. So that does not make sense at all. So she has very nicely enumerated those points. And I agree with Srinivas that patients who have cystic edema, patients who have more of HRF, I also tend to deviate towards steroids, or let me say that my threshold to shifting steroids is after 2 injections of anti-VEGF. I will shift. 2 very important points, I think, which she highlighted, which are worth emphasizing again and again, is the negative markers. Negative signs means the loss of ellipsoid zone and the drill. Because out of all, whatever she has been described, these 2, to my thinking, in clinical practice should be emphasized again and again. Drill as well as loss of this ellipsoid zone. If these are not, if these are present, so then you can tell the patient that what I tell here is the line where rods and cones are present. Cells are not much, so you may not be able to see despite anatomical success. So congratulations, excellent job done.
Yeah, thank you, Lalit sir.
Yeah, any question anybody has?
Yeah, moving on, I think the most important thing that comes to any general practitioner is the first line of treatment regarding where there are these changes by OCT biomarkers present or otherwise. So, sir, generally speaking, do you ever combine the treatment of anti-VEGF with steroids, or have you ever tried, or you said to a patient that I would like to combine both the things?
Initially, we used to, but I used to, inject, ranibizumab along with the IVTA. But presently, I don't. I do not, because you do not come to know what is being responded to. Because previous thought was that whenever there is an SRF, I always used to give ranibizumab along with IVTA. IVTA in very low dose, not the usual 4 milligram. You will give 2 milligram or even 1 milligram. Response comes. But now what I do is I will give anti-VEGF, wait for 1 or 2 injections, and then shift if it is not responding. Because we all know from all this, all this rise and ride, all these studies, the maximum response of anti-VEGF occurs in first 2 injections. If you see the graph, which is going up, but if the graph is not going up in first 2 injections, then I think you should, tentacles should go high, that this patient may require steroid. Even in phakic eyes, I don't mind shifting to Ozutrex.
I think Dr. Ganesh, just to add it here, Lalit sir answered it so well. Very relevant question, Dr. Ganesh. But with the advent of now with the newer generation of anti-VEGFs, like we have aflibercept and we have the brolucizumab, which
Yeah.
are of the longer duration and the more potency of these drugs. I think the combination of what we used to do before with IVTA with IVB or IVTA with ranibizumab has now come down with the advent of these newer kind of injections.
The other molecule is on the pipeline. The other molecule coming in pipeline in another 1 or 2 months is the faricimab.
Faricimab, yes.
Yes. Yes.
So
Right.
can I ask you one question? Srinivas, this is Dr. Nagesh from NN.
Yes, yes,
When
yes.
and it is for Divya as well. When we consider OCT biomarkers, what about the choroidal thickness, the subfoveal choroidal thickness, how it is relevant? Because nowadays we are seeing the patient of DME at the age of 25, 30 years, 35 years, where the choroid is very, very thick. And as compared to the old age, 50, 60 years, where the choroid is thin. Do you see any difference in either the course of the treatment or the response to the treatment or the end outcomes with respect to the choroidal thickness in the OCT? Have you observed and what is importance as of now when you're dealing with the DME, though it is a retinal vascular disease, how this choroid in the background plays a role?
To me or to Dr. Divya?
Anybody can answer. I just wanted to know.
Yeah, Dr. Nagesh, I think it's a very valid point. We have now observed so how the choroid behaves, whether in diabetics or not in diabetics. We also look into the choroidal vascularity index also in most of these cases. But for me to decide which anti-VEGF, looking at the choroidal thickness, I usually don't do in routine practice. But definitely it has given some clue, like in diabetics, whether it is the thinner kind of choroid which is causing more and more poor prognosis, and whether the thicker kind of choroid or having the pachy which is cause it. But I look more into the retinal layers now as of now. And then, of course, we do know how the choroid behaves in these kind of diabetics, in the later kind of diabetics. But definitely choroidal vascularity index also is another important marker which can be taken into account when we want to either go in for the anti-VEGF or with the steroid injections.
I don't think so. A lot of information is available from this respect. You see, although the focus is now shifting from retina to the choroid because of newer generation of OCT machines where we can see the choroid very well. And you are right that you see a lot of diseases. Attention is shifting to choroid, like Srinivas said about pachy is very clear. Pachy, all of us measure choroidal thickness. But what he is asking about the diabetic DME and choroidal thickness, to my theoretical thinking, I think thinner the choroid, poorer the prognosis. So that's what, but I think we should all look into it. And if you have any observation, let us know.
Yes, sir. During my talk, probably I may share a couple of cases where the choroid has kind of a different thing. Thank you. Yeah.
So let's move
we can
on.
move on to the next presentation by Dr. Divya Alex. She is a consultant vitreoretina at Ahilya Eye Foundation Eye Hospital, Kochi. Walk-in patients with diabetic macular edema. Yeah, Dr. Divya.
Is my screen visible to all?
Yes.
Okay.
Yes, Divya.
Okay. So I thank AIOS and Alagam for giving me this wonderful opportunity. So I'll straight away go into the topic. So just look at the hazard of diabetes that is causing complications in eye. So diabetes, it is a common problem that is affecting many people. So just look at the statistics. About 465 million people are living with diabetes, and in few years it is going to be double. So of these people, about 160 million are having some form of diabetic retinopathy, and of these 19 million have vision threatening DR. This is the impact of diabetes in the eye. So according to the 2022 data, the reported prevalence of DME, it ranges from about 4 to 14% in people with type 1 diabetes and about 1.5 to 5.5% in type 2 diabetes. So what is the importance of treating diabetes, DME? So if we don't treat these patients, about 50% of the eyes with DME will lose more than 2 lines of vision within 2 years of diagnosis. So treating DME is valid. So how will you evaluate such a case? So before bombarding into investigation, take a thorough ocular and systemic history about the control of diabetes, the duration of the diabetes, and especially certain coexisting factors such as anemia and renal status. These patients can deteriorate spontaneously, and some patients may be taking certain drugs such as prostaglandin analogs, thiazolidines, tamoxifen. These all can exaggerate a macular edema. The visual acuity should be recorded, IOP should be monitored, and if the IOP is high, look for neovascularization of the iris or the ankle, and if needed, a gonioscopy to look the same. The fundus examination and color fundus photography to stage the diabetic retinopathy. And next comes the optical coherence tomography or the OCT. So what we look in OCT is most commonly the central foveal thickness. And with the era of, with the advent of OCT, the use of fundus fluorescein angiography has actually decreased statistically. But in this era also, there is a considerable indication for using FFA or OCT angiography. So the first thing will be to assess the macular perfusion. So usually it will be a case of unexplained vision loss. So in this case, you can see there is a lot of capillary non-perfusion area or the dropout that is even involving the macula, enlarging the foveal avascular zone. This is a clear-cut case of macular ischemia. So the another role of fundus fluorescein angiography, as you all know, is to detect the neovascularization. But there are major two pitfalls in the fundus fluorescein angiography. That is, one is that sometimes due to the extensive leakage from the microaneurysms, the delineation of the foveal avascular zone may be confounded, and you cannot delineate the superficial capillary plexus and deep capillary plexus separately. So these two pitfalls can be beautifully overcome by the OCT angiography. So this is the superficial capillary plexus, which is located in the ganglion cell layer as well as in the inner plexiform layer. And there is a deep plexus, deep capillary plexus that is located in the deeper part of the inner nuclear layer and the outer plexiform layer. So this is OCT angiography. So there is no need for dye. So there is no question of leakage. So this can beautifully delineate or precisely delineate the foveal avascular zone. This can also identify the early changes like dilated microaneurysms, early capillary dropouts, the distortion of the foveal avascular zone, the dilatation, and the tortuosity. And one major advantage is that the OCT angiography can identify the superficial capillary plexus and deep capillary plexus separately. So this is a case of a patient with unexplained vision loss where the fundus and OCT, it is not showing anything remarkable to explain the vision loss. Even fundus fluorescein angiography, even though there are capillary dropout area, it cannot explain the vision loss. There comes the power of OCTA. So it can delineate this is the superficial capillary plexus. There is an amount of ischemia, but look at the deep capillary plexus. It can beautifully see how much ischemia has happened already in the deep capillary plexus. So why the ischemia started in deep capillary plexus first? So it is mainly due to the caliber of the vessel. So superficial capillary plexus has got larger diameter and it is more of straight. Whereas the deep capillary plexus, it is a smaller caliber and it has got a polygonal network. So it is easy to occlude and cause ischemia. So the ischemia most often started in the deep capillary plexus and later on comes into superficial capillary plexus. So in this era of OCT, even the classification of diabetic macular edema is OCT based. So it is broadly classified into non-center involving DME or the central involving DME, and it can be further classified into central involving DME with preserved visual acuity or associated with visual acuity loss. So any DME that is not involving the central 1 millimeter of the fovea, it is called as non-center involving DME. So on OCT, the central 1 millimeter will be free, but the non-central fields will be showing some amount of thickening. This subgroup of patients usually presents with good visual acuity. So how do you treat these patients? So if the visual acuity is good, so you can observe the patient, but follow-up is necessary because non-center involving can be converted into center involving DME, and the progression in year is about 14%. So if the visual acuity is less than 6/9, make sure that the visual acuity loss is due to macular edema itself. That is, rule out the other causes like cataract or any other causes like that. And if it is less than 6/9 and if it meets the CSME criteria, the macular edema can be treated with laser. So after fundus fluorescein angiography, you can directly hit the leaking microaneurysms, or you can do a pattern laser, or you can do the subthreshold laser or the nevellus. Lot of options are available. So when the diabetic macular edema involves the central 1 millimeter, it is called a center involving diabetic macular edema. So according to the Heidelberg standard, it is more than 305 in women and 320 in men. There are different patterns of diabetic macular edema. First is the spongiform pattern, in which you get a diffuse thickening with not much of cyst. And the cystoid edema, which is the most common, here you can see lot of hyporeflecting cystic spaces with the loss of the foveal contour. The other one is the neurosensory detachment causing a fluid accumulation, which is called as serous macular detachment type of DME. So these three will be the type of edema that is responding to our conventional anti-VEGF for the steroid. So the fourth one is the tractional DME. It has got a tractional element. However, you treat with the conventional therapy, this may not respond. You may have to go surgically to get a relief. So what happens exactly is that these are the tight junctions of endothelial cells in a capillary. So when there is an elevated level of VEGF and inflammatory mediators, there is loosening of the tight junctions. This causes increase in the vascular permeability, and the fluid accumulate within the retinal layers. So this fluid can accumulate, causing cyst. So the size of cyst is also very important. If it is less than 100 microns, usually the visual impact will be not much. But if it is a case of giant cyst, that is more than 200 microns, this cyst is going to compress the superficial capillary as well as the deep capillary plexus, and it causes a poor visual prognosis. And these are the neurosensory detachments. So the main mechanism is considered to be the leakage from the outer blood retinal barrier, or even the choroidal circulation exceeding the reabsorption capacity. So as long as the external limiting membrane is intact, the leakage from the inner blood retinal barrier accumulate anterior to external limiting membrane only. So recently, importance have been given to these hyperreflective foci. So there are two schools of thought. Either it can be subclinical hard exudate or the lipid extravasation, or it can be inflammatory response causing activated microglia. So it has been told that lot of number of hyperreflective foci at the baseline, this will be associated with poor visual acuity. And whenever there is a neurosensory detachment, you have to rule out underlying uncontrolled hypertension or an associated nephropathy. So how do you treat a center involving diabetic macular edema? So anti-VEGF therapy has been a godsend for many patients with diabetic macular edema, but it's not the answer for all patients. Greater personalization is still needed. So if the diabetic macular edema, if it is center involving and the vision is good, that is 6/6 parts or better, how do you treat it? The protocol V gives the answer. So they randomized 700 patients into 3 arms. So 1/3 they treated with aflibercept, 1/3 they treated with laser, 1/3 they just observed. So at the end of 2 years, they found out that there was no significant difference in the vision loss, whether it was treated with aflibercept or laser or just observed. So observation without treatment, unless visual acuity worsens, may be a reasonable strategy for these patients with good visual acuity. So what if the vision is 6/9 or worse? So till that era, only available treatment was laser. So the DRCR protocol I studied the usage of ranibizumab with laser. They wanted to know which worked better. So at the end of 1 year, they found out that intravitreal ranibizumab with prompt or deferred laser, it is much more effective than laser alone. But at the end of 3 years, they found out a very good conclusion. That was that at the end of 3 years, there was 2 groups. That is, at the intravitreal ranibizumab with prompt laser and intravitreal ranibizumab with deferred laser after 24 weeks. So they found out that the second group, the deferred laser group, had got better visual acuity rather than that of prompt laser. So the preferred practice pattern is anti-VEGF with deferred laser. So after that, a myriad of studies came. So all these trials had in common was that there was a strong visual acuity gain of more than 15 letter and improvement in the retinal anatomy, which was achieved with ranibizumab. And this visual acuity gain sustained through longer duration with minimal number of injections. But whenever there was a delayed treatment, it did not restore the same visual acuity observed in patient originally given with ranibizumab. So in 2014, the new drug aflibercept was approved for DME. There was a new kid on the block. So they wanted to know whether it is superior to ranibizumab. So considering all these ranibizumab, which anti-VEGF will you choose? So the protocol T answered this question. So they found out that if the baseline visual acuity is more than 20/40, that is 6/12, all the three drugs did an exceptionally good job. There was no difference between the three drugs. But if the visual acuity was less than 20/40, the scenario was different. They found out that aflibercept resulted in significant visual acuity gain at the end of 1 year rather than the other two drugs. But if you follow to 2 years, that difference was not persistent at the 2 years. That is, aflibercept and ranibizumab did a good job, but bevacizumab consistently performed poor even at 1 year and the second year. So the preferred practice pattern is that ranibizumab and aflibercept, they are more effective than bevacizumab when the visual acuity, the baseline visual acuity is less than 20/40. So this is the full-length antibody fragment antigen binding segment as well as the fragment crystallizing region. So this is the FAB fragment. This session is this. So at the end of this fragment antibody site, there is tiny regions called as complementarity determining regions. These are the exact antigen antibody binding site. Rest of the all antibody is to stabilize the same. So you can consider this as our bevacizumab, this is the ranibizumab, and this is the brolucizumab. And the aflibercept is the FC fusion protein. So how do you define a response after single injection? So if there is a more than 15% reduction in the central retinal thickness after 1 month of the therapy, they are identified to be good responders. But the case is not usually consistent. There is persistent fluid with anti-VEGF therapy, and it was found out that after 6 months with bevacizumab, there was about 65% of the cases with the persistent fluid. In aflibercept, it was 30%, and in ranibizumab, it was about 40%. This amount is considerably bigger. So why does this happen? So as we know the pathophysiology, the chronic hyperglycemia, there is loss of retinal capillary endothelial tight cell junction. So this causes two kinds of reaction. One is the increased expression of VEGF, and one is the increased expression of inflammatory mediators such as interleukin, TNF-alpha, etc. So this both causes vascular permeability, blood flow, and increases the macular edema. So when we are going to inject with anti-VEGF, so we are focusing only on this part, and what we tend to forget is about the inflammatory mediators. So all these inflammatory mediators can further lead to increase in the capillary perfusion as well as increase in the macular edema. So at this point of time, you can consider steroids. So steroids will take care of the inflammatory mediators. So when can you consider steroids? It can be in pseudophakic eyes or patients who are under consideration for cataract surgery in near future, who are anti-VEGF resistant, and the patients who have a recent history of CVA or CAD, and 3 months it will be contraindicated for the anti-VEGF, and pregnant patients, post-vitrectomized patients without a high IOP risk at baseline, because steroids are said to say increase in IOP, and patients who are reluctant to receive frequent injection. And there are certain biomarkers at baseline you can consider steroids or early switching to steroids. One is that this extensive hyperreflective foci, these are considered to be inflammatory mediators. And one is this pearl necklace sign or extensive hard exudate. So there are cases with post-anti-VEGF, this can precipitate at the fovea. In these cases also steroids can do better. And the other is the giant cystoid at the fovea. And the another two are markers of macular ischemia, the disorganization of the inner retinal layers, and the ellipsoid zone and the ELM loss. So studies have proven that dexamethasone implants can ameliorate drill as well as a bit of macular ischemia. So coming to all these, considering all these situations, in real life, you will lead with 4 different situations. So one is that OCT and the visual acuity shows improvement. So success can be called as if the visual acuity improved to 6 is on OCT and returned to a normal foveal contour, reversal of thickening with disappearance of cystic spaces and a neurosensory detachment. So in these cases, you can continue the treatment with anti-VEGF till the success is obtained. So the another scenario is that OCT will be showing progressive improvement, but the vision will not be improving. So continue the anti-VEGF treatment, but at the end of 3 months, you do an fundus fluorescein angiography and look for macular ischemia. And next scenario is that there is no improvement on OCT or no improvement on visual acuity gain. So at the 3 months, you can consider angiogram, or at 2 months, you can consider angiogram and then plan a rescue treatment. So you can switch to other anti-VEGF agent, or you can consider early switching to steroid if the biomarkers, as I said, is present, or consider adding lasers in the gradual course of time. And the situation 4 is the refractory DME. That is, whatever you treat, how much ever you treat, the patient is not going to get a visual acuity gain, or the patient is not getting an anatomical improvement. So refractory DME was defined as worsening of CVA by 2 lines or reduction of less than 10% retinal thickness on SD-OCT measured 1 month after at least 3 anti-VEGF injections. So this refractory DME, this also may caused by the deep capillary plexus loss. This can translate into abundant expression of VEGF. So even though the anti-VEGF may reduce the capillary permeability, this DCP has a role in circulating fluid out of the retinal layers. So whenever there is an ischemia or the loss of the DCP, that would reduce the fluid absorption, even though the anti-VEGF is reducing capillary permeability. So the question is the central macular thickness alone sufficient to predict a treatment response? So new European Society Associated Classification says that you have to look at the 7 parameters to say the treatment response and to answer the patient whether you are going to get a good visual acuity in the treatment course. So one is the foveal thickness, one is the size of intraretinal cyst. As I said, the larger the size of the cyst, the poorer the prognosis. And when one is the EZ and the ELM status. That is, whenever there is an EZ loss, there will be poor prognostic indicator. And dissociation of inner retinal layers, disorganization of the inner retinal layers, drill is also associated with poor prognostic factor. Larger the number of hyperreflective foci, that is also associated with a poor prognostic factor. And always look at the vitreoretinal relationship also. So the patient education is also very important as you go on the treatment, and make them understand that the number of anti-VEGF injection required to achieve the desired visual acuity decreases substantially after the first year, and with the majority of the patient not requiring further treatment after 3 years. And you should have a key collaboration between the retina specialist, the diabetologist, the physician, because systemic control also is very important in managing diabetic macular edema. So I thank once again.
Thank you, Divya Alex, for a wonderful presentation and beautifully demonstrating different situation and the management of such patients. You have highlighted all the aspects pretty clearly for everyone to understand. I'd like to get comments from Dr. Lalit Verma, sir.
You see, excellent talk. The only comment I have here is that, she classified DME into... we should also include, we should say whether it is tractional, non-tractional, then jump to center involving, non-center involving. So first thing should be surgical rule out. That's the other thing is I would like that this particular webinar, which is being run, walk-in retina patients, we should not make it look like this talk. Talk was excellent. All the points have been covered. It should be focus should be slightly different. That once the patient comes, this is what has to be done. Once the patient comes, what I do is patient-related factors. There are 5 of them, like hemoglobin, like triglyceride. Let's not become injectors. All of us are becoming injectors. Everybody wants to inject. Protocol T or protocol I or so many things. We should, diabetic macular edema is not urgency at all. Evaluation of patient, which include drug history, sleep apnea, triglycerides, anemia, kidney status. I would like to stabilize those patients and then counsel, like last 2 slides are wonderful actually, how to, counsel these patients, and let's all take a pledge. But the flow of this should not be like a pure lecture. That I think she should be called to one of the AIOS, diabetic forums where this talk should be re-delivered. And excellent job done. But don't forget traction. Don't forget the patient factors like hemoglobin, lipid levels, even sleep apnea, and so many other things, which are very, very important.
Thank you, sir.
Yeah. So, Dr. Nagesha, any thoughts on the whole process? You have your next talk coming before that.
Just I wanted to ask Deep, it was excellent talk. When you said about DCP, I just wanted to know how it looks like in the OCT. Can you just translate the DCP, deep capillary plexus loss in the OCT? Could you able to make out in the OCT these scans, whether you will have a drill or whether you will have a AIOS loss? What exactly? If you don't have an octa, whether you could able to make out in the OCT the deep capillary, the effects of the deep capillary loss. That's what a very interesting point you raised for the non-responsiveness. I just wanted to see if any OCT signatures can tell you the superficial capillary plexus are intact, but the deep capillary plexus are not intact. There's something wrong with the deep capillary plexus.
There is something called as disorganization of the outer retinal layers also. That is something new that has been studied with the DCP. So when there is an extensive loss of DCP that is seen in OCT angiography, you can even see that disorganization of the layer in the outer plexiform layer also. That is one thing they have studied newly.
Yeah, that was very interesting. Thank you.
Yeah. So moving on to the next presentation, I think we will cover a lot of points there as well. Dr. C.K. Nagdesha sir, Consultant Department of Retina from Narayan Nethralaya, Bangalore. His talk is on hurdles in DME management, a case-based discussion. Yeah, Dr. Nagesha sir.
Shall I see the screen?
Yeah, Dr. Nagesha.
My screen is visible?
Yes, yes.
Yeah, fine. So after the two lectures, it will be easy for me to go through the reality or the way how we come across the diabetic macular edema cases in clinics and what are the hurdles we do see them, right? This is very important because probably the diabetic retinopathy and diabetic macular edema could be the most probable referrals by a general ophthalmologist to the subspecialty clinic. I think it's a good idea. They should know exactly what the DME can present with and what could be the codes and what could be the outcomes. And they can just give a overview to the patient at the first door itself so that it will be easy for us to, take them for the treatment. So I'll be going through a couple of cases and then we'll just see what are the difficulties in managing a DME and what are the lessons we learned and how the ophthalmologist should be aware of all those things before referring them to a subspecialty. So I'll be going through simple cases. This is a 50-year-old male diabetic for the last 7 years and hypertensive.
A little bit louder if you can.
Oh, sorry. Yeah. Now, can you hear me now?
Yeah, better.
Am I louder now? Yeah. So this is a 50-year-old male with diabetes for 7 years and hypertension 15 years. He had diminished vision elsewhere. He got treated for the focal laser for the succinates. Now he came with a 6/9 vision in the right eye. If you could see the OCT, there is a cystoid macular edema involving the center. And now the plan is very, very simple. So anti-VEGF injections, give 1 or 2 anti-VEGF injections. Everything is clear. The patient is happy and even the doctor is happy. So what is the point is to ponder here? It is basically a win-win situation. Both doctor and the patients are happy and everyone's, of course, it's a dream case, even for the retina specialist as well as for general ophthalmologist. But keep in mind, this is every day is not a Sunday at all. So we hardly get to see these kind of cases in a routine clinic, maybe not more than 10 to 15%. So what's the problem with this? Now look at this case again. So this is a 76-year-old male. He lost his left eye vision for the advanced glaucoma because of the hypermature cataract. This is a right eye fundus picture with OCT picture. So you could see some amount of focal laser done temporal to the fovea with the hard exudates. At the fovea, there is a large cystoid space. Our vision is 6/9. So now, so what to do with this? And again, we think it is a straightforward case. Just go and inject, probably should go off. So we tried giving an anti-VEGF injection in the beginning, first baseline, second, third, fourth. So not responded so well. And we shifted to the newer injections like brolucizumab. Again, it was a little bit of not like a suboptimal response, not a great response. So throughout the course of last 6 months, patient maintained 6/9 vision. Now what next? So this is a problem. So you might have, many people might have faced this kind of problems, suboptimal response, but patient is still maintaining 6/9 and one-eyed. What to do with this patient? So point to ponder here is sentinel involving macular edema with good vision. So we have a protocol B as a backup. If somebody asks me why you're not treating and why you're treating, we have a protocol B as a backup. And hard to leave this patient untreated. So we can't just say, no need to treat because vision is good. And it may be very time difficult to leave this one-eyed patient without treatment. So, and of course, many times it's not a single injection. You may go through a couple of injections or multiple injections for over a period of time, though we are not sure whether vision will go back to 6/6 or it may remain 6/9. So this is how the ambiguity prevails when you follow the protocols. So now look at the second case. This is a 55-year-old male, diabetic for 14 years. He had very bad control of sugars. We asked them to come back with a good control. After 3 weeks, they come back for the treatment. So right eye and left eye, a lot of hard auxiliaries with subretinal OCT shows subretinal fluid. In the left eye also, what is OCT shows subretinal fluid, which has higher density echo compared to the right eye. We thought probably steroid should be a better one for the left eye, not the anti-VEGF. So before planning that, I wanted to see what is a capillary perfusion of the macula. Apparently, it looks very, very good. I was very, very happy. Probably they may do well with the Azurdex implants. So this what happened after Azurdex implant. Look at the left eye. All the auxiliaries settled nicely under the fovea. Vision dropped from 6/18 to 6/36. Now, what it tells about us. So when the creeping hard auxiliaries are there from the diffuse blood vessel dysfunction, even with a well-perfused macula, high density SRF in the OCT, irrespective whether you give anti-VEGF or steroids, they creep in under the fovea and it may upset your results. So what is more important here is we need to look at the blood, the capillary perfusion and underlying RPE, how good it is. Probably those who have the capillary good perfusion at the fovea, probably over a period of time, these hard auxiliaries may disappear, leaving behind some amount of vision loss. So going to the case 3, again, this is a 56-year-old male who had diabetes for 8 years. And this looks quite simple, where FFA shows a small 2 focal leaks at the foveal margin, and the OCT shows a simple foveal cyst. And when you look carefully at the zoomed OCT image, I can see large kind of a microaneurysm which appears large. You can call it as a macroaneurysm at the foveal vascular zone. So whenever we see this kind of macroaneurysms at the foveal vascular zone, so we are not so happy, because can you see, I'm not scaring anybody. Can you just see that this is a serial of OCT photographs of the same eye over a period of say 10 years, how this single macroaneurysm sitting at the foveal vascular zone causing multiple recurrences. This gentleman took more than 20 to 25 injections, everything altogether, whatever available in the market. So it regresses with the anti-VEGF or steroids or whatever you give, but again it comes back. So this is a problem with this kind of capillary, malformations that are there around the foveal area, where a single cyst can, make you exhausted with the multiple injections over a period of time. So again, the same patient after multiple injections developed a taut highlight. Again, we did vitrectomy. Then again, this edema is recurring. Again, post vitrectomy, we had given a couple of injections, more than 3-4 Azurdex injections. So it persists, keep on persisting. So the points here to ponder is when we have this macroaneurysms or abnormal vascular network at the foveal area, so they are the culprits under the mask. So they keep the DME alive for years. The good thing is they don't resist the injection. They respond very well with injection, but they're very, very consistent in the recurrences. So this tells a story that DME can last long, like a marathon, for years together. So look at the case 4. Again, this is kind of a similar case where the left eye, if you see, there's little hard auxiliaries are there, and then the OCT shows a subretinal fluid with a lot of interretinal fluid. So we just thought we can give an Azurdex and all. This gentleman again took a lot of injections. With every injection, it responds well. Again, it comes back. I showed a couple of OCT images. Can you see here where the subfoveal choroidal thickness is very, very thick? It looks like a dome shape in the vertical section, and the choroid, other than the foveal area, it looks very, very thin. So I was doubting probably this is a choroid which is causing, or it could have some effect on multiple recurrences. So points to ponder here is, the vision improves with every injection over a period of time. So the main indication why we keep injecting this kind of patient is with every injection, the vision improves, and that is an indication to give another injection, another injection. Of course, the bone tired doctors and the patient, when you treat this kind of patients who had increased choroidal thickness under the fovea, which can cause lot of leakage over a period of time. Again, this is a case 5 where it's very, very obvious we have a lot of vitreomacular traction in the right eye, and I'm more interested in the left eye where we have a lot of asteroid AIOS with a thick hyaloid. So the plan was to do a surgery for the right eye and then the laser to the left eye along with an injection, hoping this will remain the same. So right eye surgery done probably is improved to 612. The left eye over a period of time, after PRP, the posterior hyaloid started lifting up, causing vitreomacular traction, and the vision dropped to 6/18. So again, we had to do surgery for the vitreomacular traction in the left eye, and then vision improved to 612. So here, whenever we have this posterior hyaloid in eyes with a dense asteroid hyalosis, they're really not friendly at all. So that takes the DME treatment into disarray. Many times we may land up in having a tractional component which may need a surgery in this kind of cases. So what it means to general ophthalmologists, basically, DME could be as simple as one shot treatment to as everlasting as a marathon. And majority of the DME may not get away with a single digit injections and may need surgery also, just like how I showed in the last case. And so give them a real life picture before even think of referring these kind of patients. So we'll go to another set of cases where this is a case number 6, where 50-year-old diabetic for he had best corrected visual acuity 612 in the right and 6/9 in the left eye. If you look carefully, there is a parafoveal hue in the right, and then there's kind of a pigmentation at the parafoveal region. Probably we will be dealing with the parafoveal telangiectasia or macular telangiectasia, which is quite common in diabetic patients. Look at the OCT, how it looks like a dome-shaped foveal detachment with the shagging of the outer segments. You may sometimes think, and you may refer this patient to the diabetic macular edema, but no, you may have this kind of exudation without having a CNVM in a patient with a PFT. We call it as a non-CNVM exudative PFT forms. So this patient, again, he had a kind of a diffuse edema temple to the foveal area in the left eye. We just did a FFA to look at whether there is a CNVM. There is no CNVM as such. There is no CSR. Just a background diabetic retinopathy with a lot of leakage around the macular area because of the PFT. So we did a focal laser to the left eye for the non-central macular edema, and the right eye had a PDR, so we did a PRP laser. For the right eye, we thought of giving anti-VEGF injections, but it won't respond, frankly speaking. These PFT associated neurosensitive detachment, they remain as it is for months together. So what we need to learn about is non-exudative foveal detachment in macula is quite common, and they do see in patients with the diabetic retinopathy. We should not confuse that with the diabetic macular edema. And of course, this foveal detachment is because of the blood retinal ganglion dysfunction that is aggravated by the diabetic retinopathy. And as I said, they're very, very adamant. They don't respond to the DME management. They do respond to the steroids. Again, they come back after steroid responses goes off. Better not to chase these kind of OCTs in a practice. So going to the seventh case, this is again a straightforward case, a 39-year-old diabetes with hypertension. It looks like a mixed retinopathy with a lot of macular edema. And one thing I was obviously looking at is quite of large choroidal vessels in the right eye as well as in the left eye. So when we thought of giving an Azodex injection to the left eye and anti-VEGF injection in the right eye, Azodex injection caused decrease in the macular thickening in the left eye. You look at the right eye, I could see a large choroidal vessels, and somewhere I could see the choreocapillaries are thinned out or it's compressed. It looks like a packy, vessels over here. So over a period of time, so he developed a kind of a neurosensitive detachment. I was not sure whether it is a DME or the CSR. And after he lost a follow-up and he came back after 8 months, I could see a large PD, the subretinal fluid. And when I carefully looked at choroidal thickness, I could see a lot of packy vessels with the compression of the choreocapillaries. So in fact, we gave the Azodex to the left eye. He did the CSR in the right eye. I'm really not at all sure what caused what, whether the CSR was just happened just like that, or it could be a cross, effect of Azodex in the left eye causing a right eye CSR. So again, we did a FFA to see if there is any leakage. There is no obvious leakage as such. So we just stopped treatment and just observed over a period of next 1 year. So the CSR PD flattened and then SRFA started resolving well. So Nowadays, EDI imaging has increased the prevalence of the pachychoroid. In fact, and we are looking more and more cases of pachychoroid in this kind of patients who are deemed to be a DME patients. And of course, so as we detect the pachychoroid and then show the complications also along with it. So CSR may join the DME and then trickle your brain, and then you may think it is a DME, but may not be a DME. Rather, it is a coexisting both CSR and the brain, DME. So what it means to general ophthalmologists, so DR became a universal background presentation. And over that, you can have a different kind of pathologies. So good examination, clinical examination in the clinic is paramount important to identify if there are any coexisting diseases along with the diabetic retinopathy and diabetic macular edema. This is the last case. Again, sometimes you may see a patient who had a very diffuse, blood retinal dysfunction, kind of, course-like response. And this was a patient who had, who underwent cataract surgery, who had a macular traction. So we did a surgery for the macular traction, and then post-surgery, the dysfunction has improved because of the removal of the vitreous. But again, he had a lot of recurrences post-vitrectomy, and it is very, very difficult to treat post-vitrectomy diabetic macular edema. And this patient again received multiple intravitreal triamcinolone Nazutex. So they keep recurring over a period of time. Right? So diffuse PRB dysfunction stabilizes well with the vitreous removal. So macular edema in vitrectomy is again very, very big task, whether they may not respond. They do respond, but they need multiple settings or multiple injections on over a period of time. So this is the last case where this patient was treated by myself as a diabetic macular edema for 6 months. The FFA does not show much leakage, but OCT was very, very dramatic, having a large subretinal fluid in the left eye and the right eye. When I treated with Azurex, IVT, anti-VEGF, one thing I observed was macular edema just progressive. So then I just sat back and I went back and I just saw a systemic evaluation done. His hemoglobin was very, very poor, 6 hemoglobin. His serum electrophoresis showed very high globulin. And then he was diagnosed by our medicine colleague as a well-understood macroglobulinemia. And we named the fundus finding the macular edema as paraproteinemic maculopathy. After that, he received rituximab chemo, and the macular edema completely resolved in the both eyes. So the next time when I called him, the parents attended told me the patient died because of the increased ICT and all those things. The guilt still remained with me because I could not able to diagnose this paraproteinemic maculopathy for the first 6 months, though patient did not had any other systemic complaints except for the diabetic macular edema. So here, systemic diseases are very, very dramatic, democratic, because they have freedom of expression. They may express fully, they may not express fully, but it is our duty to find out from the basic investigations or basic clinical examination at the first encounter. So it means, so many times we may overlook the underlying systemic diseases when we see a diabetic retinopathy and diabetic macular edema. I think at the last, the basic general examination and workup is the first to encounter, just to save one's life. Right, this is a nutshell. I was just telling you about simple foveal edema. It's a win-win situation. It's desired, but it has a pinch of salt. To take it up. When you have hard oxidates, if it want to creep, it will creep. When you have macroaneurysms, so very responsive treatment, but consistent with the recurrences. When sometimes the edema may be very, very protracted cases, and they're not uncommon. So we need to have a lot of patience and the perseverance, both by the doctor and the patients. Sometimes you may have intramacular tractions with the patient who have asteroid hyalosis, though hyalosis looks very spectacular, but they're really dirty in its function. And we have comorbid conditions along with the diabetic macular edema like PFT, we can have CSR, we can have diffuse retinal pancreas. All these things general ophthalmologists should be aware of when they are looking at patient with diabetic macular edema. And sometimes simple general examination, simple blood counts can save one's life. Of course, the last case is a dream case. Everybody want to have this kind of cases in their clinic, but that is just a tip of the iceberg, right? Thank you so much.
Thank you, Dr. Nagesha Krishnappa, sir, for a wonderful presentation. This is, you have put together all the interesting cases and all the confusing ones together, where generally anyone can get really swayed away by the diabetes per se. Just to add on to that thing, sir, have you ever tried suprachoroidal steroids for any of the DME patients? And the second thing is, how commonly do you use a macular grid for such patients or DME patients?
Yeah, suprachoroidal IVT, I didn't try because in the beginning, a lot of people had an interest on it, but somehow it did not work consistently for all the patients. I never tried with that. And coming to the lasers, I keep my lasers only for sursinates. When you have a typical sursinates, and of course, I showed a couple of patients in the beginning where they had a very chronic, course. So I may do a modified grid in them. So I'm not doing a grid at all, but modified grid also exclusively for those who had taken at least treatment for first 6 months or 8 months. Otherwise, most of the times I'll prefer it only for the sursinates, typical and classical sursinates. That's all.
Yeah, going back to Divya, what she highlighted on her slides about the deep capillary plexus and their role in probably the leakage persistent of fluid. Do you think a posterior subtenon triamcinolone may, in addition to anti-VEGF, also reduce the inflammatory markers which are there?
Sir, theoretically, inflammatory markers should be reduced, but what they say in deep capillary plexus is abundant expression of VEGF only. So otherwise, the inflammatory markers, it should be theoretically done with this thing, steroids. But in DCP loss, I think VEGF is the culprit.
So there is one question which says how you have demonstrated about brolucizumab being used also as one of the treatment modalities, and it has been approved. So how commonly do you use it? And obviously, any reactions that you may have seen?
I have used it only in refractory diabetic macular edema, but I have never got a wow effect as we get in NMD or PCV with the brolucizumab. So actually, I wanted to ask the seniors what is their experience on refractory DME and this brolucizumab, because I have given in 4 cases, and these 4 cases actually with even with Osudex, I get an anatomical improvement. But with my personal experience, I didn't even get an anatomical improvement. Forget about the visual improvement.
And I will put that question to Dr. Dairis Shroff.
Yeah, hi. I think some of these cases which are very refractory, they definitely respond better to the steroids compared to the Ozurdex, compared to brolucizumab. And I generally use brolucizumab for recalcitrant cases which have glaucoma, because in those steroids are contraindicated. So you can reserve this for those patients, I think.
So have you got at least anatomical recovery in those cases?
In a few cases I have got, yes. But yeah, you're right. I think overall the steroids work better for these really, really bad cases.
Yes.
So I had a question, if I may.
Yeah.
So
Yeah,
what
Hitesh.
is your line of treatment in vitrectomized eyes having diabetic macular edema? Because that is also a slightly difficult thing to treat. So what do you start with?
Vitrectomized eyes, generally, I do start with a DEX implant, and I
Okay.
found it very good. In fact, I had a patient who we operated for diabetic vitrectomy, and there was oil in situ, but it was a one-eyed patient with massive edema. So we didn't know what to do, and actually injected the DEX implant into the oil, and the patient did very well. And then I was comfortable doing a SOR after 2 months after. In fact, I did a SOR after about 6 months after that. So
Okay.
it
Is it
worked
true
well.
that suprachoroidal steroids work better in oil-filled eyes or vitrectomized eyes?
I don't have any personal experience of that, so I don't know about that.
Okay, sir. Thank you, sir.
Dr. Nagesha, your comments on brolucizumab?
Yeah, brolucizumab I have used for a couple of patients. Regarding the adverse events in the brolucizumab, we had a couple of patients who had atopic dermatitis, right? And we overlooked it, and then we gave a brolucizumab, and then he came back after third brolucizumab with a lot of skin lesions, and I got a letter from the dermatologist saying, can you just look into the injection if at all, if it is causing exacerbation of the atopic dermatitis? In fact, he came with a lot of dermatitis patches in the palm altogether. I was just so scared, and I stopped brolucizumab in that patient. And another patient who had kind of AC cells or old pigments in the cornea, and then overlooked, and then we gave injection. And I think it is a third injection again, that the patient, he came back with an inflammation. And then when we walked up, our VA colleagues walked up, they saw some kind of a choroiditis patch under the, the parafoveal area. We sent them for the, tuberculosis. We investigated further. He found to have latent TB in this patient. So we are not sure in both the cases, it is a type 4 hypersensitivity reaction that we observed. Since then, we are very, very cautious. And in fact, we have made a kind of a pro forma whenever we want to give a brolucizumab to the patient, where it has yes or no columns stating so many allergies, if at all, if you have it. And then we made it a mandate now for each patient who take up this brolucizumab. And that's the thing. Apart from that, brolucizumab for the DME, I haven't seen wow response just the way how you get the Najudex. So we do get the response, but it's not anatomically, it doesn't seems like a superior to the Najudex. But of course, it is very fantastic for the ARMD and the PCV cases. Yeah.
Just to put a common question, which every ophthalmologist probably may ask, is regarding the IOP increase related to dexamethasone implant. How commonly do you see it in your practice, and how easily is it manageable? First to Dr. Direshwar.
So I think we were getting this much more with the IVTA, frankly, compared to the DEX implants. And I think after using thousands of DEX implants, I know personally only of one patient who needed a trab, which just goes to show how rare it is. Of course, we are cautious, and if we have a doubt, we do get a glaucoma clearance if there's a doubt. But overall, I've had quite a good experience. I don't know what the Narayana trial experience is, Dr. Nagesha.
Yeah, I think we have a very quite good experience with Azodex. Most of the times, either it go 24, 26, and maximum 28, 30, and it will go away with a single drug. And we never had an trap like in IOP rise or persistent rise. It is quite safe. In fact, the second injection, when we give the second injection, though we knew that first injection cost 24, 26, it comes down after the drug is gone. And the second injection, again, it comes the same thing. It is not additive as such. So second injection, again, it may go to 24, 26. We'll put on some anti-glaucoma medication, it will come down. So that's a really good thing with the Azodex implants. Each injection is a new injection there.
Yes.
Yeah. Any tips for general retina surgeons that this implant does not come into the visual field?
I think most important tip is that don't put it in patients who have an ACIOL. That is a totally contraindication. Of course, aphakic patients, because then you're asking for trouble, and then it can come in the anterior chamber and cause a rise in pressure and corneal edema. So that is one tip, that you totally avoid it in such sort of patients where the IOL is not stable. Even I would be wary of putting it in patients who have a SF-IOL, because we really don't have a good barrier.
Dr. Nagesha?
Yeah, another tip, many times I've seen my students injecting it just under the sclera, where it stays near the pars plana region, where that is quite near to the ciliary body, right, at the trabecular meshwork. Rather, I suggest put the needle deep inside and then leave that with, the Azodex implant in the posterior vitreous, not in the anterior vitreous, because I've seen those who are left in the anterior vitreous tend to have higher IOP compared to those who are left in the deep, the posterior vitreous cavity. That's the one thing.
Yeah, that's a very good tip, because today I had a patient who was referred to me who had the Azodex implant inside the crystalline lens with the intumescent cataract. So I think this serves both the purposes.
True. Just to highlight one more point about injecting the Azodex implant. So any particular way that you inject so that the velocity of implant reduces? Or you have noticed it to go very fast sometimes?
You can gently press it and release it. I don't really think it matters so much. If you're worried, then direct it away from the fovea. I think that's always good. Make sure your direction of the injection is such so that it's directed towards the nasal periphery. So if you're worried about that, I think that is a small tip. We used to do it earlier. I don't think we worry about it too much now. But yeah, I think the velocity we are much more worried about in a vitrectomized eye, because when there's a vitreous, we're not concerned. But in a vitrectomized eye, yes. Other thing, if you have a vitrectomy, I would suggest just keep a vitreous suture ready, although I think hardly ever done it. But sometimes if a vitrectomy is very complete, these are the eyes which can become a little soft because there's nothing to plug that kind of a wound. But the advantage is newer Ozurdex has got that sharper blade, and we are not seeing this complication so often nowadays. In the first generation implants, we used to see this leakage.
True. Dr. Nagesha?
I think sir has added everything. The only thing is we have this classical teaching, direct the needle towards the center of the vitreous and then inject whatever the injection, whether it is intravitreal antibiotics or not. But I think for the Ozurdex, that should not be the case. So in the context of injecting into the center of the vitreous, you'll be touching the lens, or sometimes you'll go into the lens. A lot of things happens. Rather, I suggest them to just go vertically and you inject, because it is very, very difficult to touch the retina with the needle. It's impossible to touch the retina when you're going to the pars plana, because you need to bend, a lot of degrees to touch the retina. It never touches the retina. So that's the one tip, probably I can give. Just go, keep the eye in the primary position, maybe just go vertically, inject it. It will go and sit in the inferior vitreous rather than directing towards the mid vitreous or somewhere else.
Yeah, I think we have covered a lot of diabetic retinopathy cases. Moving on to interesting topic with Dr. Darius Shroff, who's a medical director of Retina Vitreous Services Shroff Eye Center, New Delhi, about peripheral exudative hemorrhagic chorioretinopathy. Dr. Darius Shroff, sir.
Hi, good evening. I'd like to thank Dr. Santosh Honawar and AIOS for this opportunity, and this opportunity to speak of one of my favorite diseases, something which I feel that it is very common, but we don't speak enough about it. So I'll just talk about 3 patients who kind of walked in with this disease, in like a walk-in patient to our retina OPD, and how we tackled them and what is the message from this. So this was the first patient who just came in with drop in vision in the right eye. You can see vision is 6/60, and this is a very, very ordinary posterior pole photograph of the retina. But you can see the right eye, there's subretinal heme involving the macula. And I don't have it in the picture, but there was hemorrhagic mounds in the inferior temporal and superior temporal quadrant in this patient. So when you see a patient like that, what do you think of? What would be your DDs? So most probably you think of PCV, or it could be a macroaneurysm. Melanoma, of course, is not there, but just because the mounds were in the periphery, melanoma could be a DD, or it could be peripheral exudative hemorrhagic chorioretinopathy. So we did some imaging. That time we did not have the wide field imaging. So this is the conventional FFA, which showed the block fluorescence. And when the ICG, there was no polyps. Of course, again, this is a posterior pole ICG, not involving the mounds, but no definite polyps. And the OCT, you can see a subfoveal neurosensory detachment with subretinal heme. So although this OCT doesn't look very dramatic, this little bit of blood was causing the drop in vision. Ultrasound of that area in the periphery showed small echozoic lesions with high internal reflectivity. There was no acoustic hollowing. So we diagnosed it at PHCR. We gave anti-VEGF injections because of the hemorrhage. And you can see, lo and behold, the heme is totally cleared. And what I also do in these cases is the leakage which we see in the periphery. We did a little bit of focal laser, and the OCT is dry. So the top OCT is before the therapy and the lower OCT is post-therapy. So this is how the patient did well, and he was saved from excessive investigations thinking it was a tumor. Second patient, I think now we have seen so much of DME. So just move track. This was a non-diabetic patient. So that's the disclaimer, but this could be any sort of, this is a macular edema. There's a neurosensory detachment and cystoid spaces. And it's again, an elderly patient. So you're wondering, what is this patient? Because patient had not undergone a proper fundus exam yet. And lo and behold, see the color photo. You can see this exudative mass here with some hemorrhage. We did the imaging. You can see the block fluorescence because of the hemorrhage and some leakage and a little bit of leakage and staining at the posterior pole. And this was again a case of PHCR, which we found out on multimodal imaging. Again, anti-VEGF given, and the macula is dry. Of course, we continued following up this patient. The third case, my last case. So this was a 70-year-old patient who actually was hypertensive and diabetic and presented with diminution of vision. History was only 5 days and was pseudophakic. So this was a patient who was referred to us as a tumor in the eye. And you can see this temporal mass lesion, and we were wondering what it was. Of course, because we are seeing a lot of PHR patients, we had this, but it was basically referred to us as melanoma. Now, when we see the full picture, you can see that this is a mass lesion temporally, but there's a detachment also all around, which is seen on this Amsler chart. We did a multimodal imaging. So in the FFA ICG, you can see block fluorescence. These vessels are looking distorted because this is detached retina. So that's why the vessels are looking odd. Ultrasound B scan is showing this is a detachment, retinal detachment, and this is heme. So the fluid is not clear in this kind of ultrasound. And you see the OCT is also very interesting. You can see the subretinal heme and fluid causing this detachment. And this is extending right from the periphery, and even the fovea is detached with some heme under the fovea. So again, this was PHCR, and of course the treatment is anti-VEGF. So, and you can see how beautifully the patient has responded. So this was just post 2 injections. You can see the mass is gone. And this was somebody, I mean, if we are not aware of this diagnosis, some people may even enucleate such an eye. So this is something which is important. I would like Dr. Santosh's comments also, because he's the master of tumors. But this is important that this simple and any sort of anti-VEGF injection, whatever you want, you can inject. And you can see ultrasound is normal and OCT is back, little cystoid spaces, and we repeated the injections. So what is this peculiar entity which I'm speaking about? What on earth is this PHCR? It has a very, very long name. It has a 47-letter name. But I think don't let that dazzle you. It was first described in 1961 by Rees and Jones, and the term was coined by Ansley. And the largest series is by the Shields group. And this was 173 eyes where PHCR simulated looked like a choroidal melanoma. So basically, it involves extramacular hemorrhagic RPDs, basically pigment epithelial detachments, which have fluid, hemorrhage, scarring associated with them. It's seen in old elderly patients and is associated with ARMD. Patients are asymptomatic until the macula gets involved or there's vitreous hemorrhage. So in fact, the fourth case, which I was going to show, was just vitreous hemorrhage, but there's nothing to it. Basically, one more presentation is a patient can just come with blood in the eye. You know, there's nothing, no picture to be shown, and that could also be an underlying PHCR. So these are some textbook and some of our pictures where you can see these mounds of blood. And when they involve the posterior pole, that's when the patient is going to present to you. It has been described as a potential blinding disorder of elderly Caucasians. And Shields, of course, they did a study in America. So they found that 99% were Caucasians. But this entity has been rarely reported from the Indian subcontinent. It's rare, but not unknown in our country. It's underdiagnosed, I think, because of the location in periphery and the asymptomatic course in patients. And like what I want to emphasize is, although wide field imaging and very fancy, expensive cameras help to document and treat these to a certain extent, all that you need to diagnose this entity is a good indirect ophthalmoscopic exam. So this is my message for general ophthalmologists, that you don't need any expensive or fancy equipment to be able to diagnose this. Of course, to image it, you may need, but to diagnose it, a good old normal indirect ophthalmoscope and 20 diopter lens is all that you need to diagnose PHCR. It's a disease interrupted. So when I put this in PubMed search, you can see the first article description was 1980, and then the next was 2005. So you can see there's a real upsurge in interest in this disease entity, and now there are multiple publications on this. This is something I would like Dr. Santosh Hanawa's comments also, because I think most important is that we don't confuse this with melanoma. And the age group is different. PHCR is in older patients, whereas the melanoma is in the middle-aged patients. It is often bilateral. The PHCR melanoma is mainly unilateral. And the focality is also different. The PHCR lesions are multifocal, whereas you get the mushroom unifocal lesion in cases of melanoma. Other things, you should see the fellow travelers along with PHCR. So if you have macular drusen, macular RP changes, macular CNVM, or peripheral drusen or peripheral RP changes, this is more in the PHCR subgroup compared to melanoma. So this kind of gives you a telltale sign that what you're looking at. Of course, we retina doctors all depend a lot on our investigations. So ultrasound is very important. And like I described in the first case, the B scan is important. The B scan acoustic quality, it will be echogenic or dense in PHCR because there's blood, whereas in melanoma, it will be hollow or echolucent. And the A scan internal refractivity will be high internal reflectivity because of the heme, whereas in melanoma, it will have low internal reflectivity. And also the choroidal excavation sign will be seen in melanoma, which will not be seen in PHCR. FFA, I shown you some of them. Basically, in PHCR, you will have blocked fluorescence, and rarely you will see a CNVM. Whereas in melanoma, you may see the intrinsic vascularity of the mass with double circulation. And ICG, I think, is very important because classically it's described with hotspots, but we are seeing a lot of polyps in patients of PHCR, whereas in the melanoma, you see the intrinsic vascularity of the mass. So here, again, because we are very fond of wide field imaging, you can see this patient wide field image, Optos color photo of a PHCR. And when we do ICG, you can see how beautifully you can pick up the polyps at the margin of the PHCR lesion. And now we are even doing wide field OCT and OCTA. So this is the swept source OCT, and you can see how beautifully these are the polyps on ICG, but you can even make out by doing a lot of sectioning and segmentation. You can pick up the cluster of polyps on wide field OCT angiography. And we know that they are polyps because you can see the flow on the B scan, these red dots, and this is in the same corresponding area. So you're able to pick up these polyps in PHCR using all three modalities. Other thing, what about, we were talking a little bit in the beginning about the choroidal contour in DME, but what about PHCR? So based on choroidal contour, which we saw on 16 millimeter scans, B scans, we found when I saw some of these patients that normally if you see any normal control eye, your eye, you'll have a bowl shaped choroid, you know, it's like a bowl, the katori, it's bowing down here in the center. The thickest choroid is in the center. But PHCR is a club shaped choroid because obviously because there's a lesion in the periphery. So choroid becomes thicker in the periphery. So based on that, we published in Retina and felt that PHCR should be a new addition to the pachychoroid disease spectrum. So what's the problem? It is a diagnostic conundrum. This we've already discussed in detail because of its DDs, which could be ominous. But what about treatment? There's no treatment guideline. Should we observe? Should we treat? What is the best modality? And what is the endpoint of treatment? Nobody knows this. Some of the options are anti-VEGF, which I showed you, laser, which I did in some of my cases. Other people say you do cryo, PDT, combo therapy. I mean, and only thing where everybody is, there's a kind of consensus is if there's blood in the eye, then you should do a vitrectomy. And basically for non-resolving vitreous hemorrhage. Based on some of our findings, we kind of proposed a kind of treatment algorithm where we found that if there's only diffuse hypofluorescence, and no definite leakage, anti-VEGF only works. But if there's irregular hypofluorescence with definite area of leakage, you can give anti-VEGF, let the mount come down a bit and do a little focal laser. The other subgroup where we found this useful was where we actually picked up definite polyps. So these are the areas, patients you can give anti-VEGF and do focal laser. If the lesions are inactive, all that's required is to observe these patients. In contrast to treatment of macular CNV, these peripheral lesions don't need to be totally dry. So don't get obsessive about giving too many anti-VEGFs in these patients. So it's not, you don't have to follow protocols which are there in AMD for these patients. You just have to get clinical stabilization. So the last slide, it's a peripheral exudative hemorrhagic retinal degenerative process. It's more common than we think. You just need to look out for it. And there's no accepted definite treatment protocol, and we can value the opinion of the panelists. Thank you.
Thank you, Dr. Darishov, sir, for a wonderful presentation and highlighting the entity in detail. Probably it's a very not well that understood entity as such. And Dr. Santosh, sir, your comments on differentiating both these entities.
Very well presented, and we keep seeing these. I know it is not as common as in Caucasians, but we do see as in a referral practice, there is a bunch of cases that come in as referred as melanoma, necrotic melanoma, some following vitrectomy, because these patients in India, at least, they tend to present with vitreous hemorrhage. They don't actually go to an ophthalmologist. They already have a background of ARMD, so they don't really, appreciate a drastic reduction in vision when they have these lesions encroaching on the macula. So the bleed encroaching on the macula, or if they have a vitreous hemorrhage. So they generally go when there is a full-blown vitreous hemorrhage, and on ultrasound, it can simulate a melanoma. So these patients often get vitrectomy done, and then they are presented for plaque brachytherapy. And some of them I have had cases where they have done enucleation, and following enucleation, there was no tumor found. So pathologists send these over the slides for a re-evaluation, etc. So this is definitely there. And then differences were very well brought out at Darius. I have nothing to add to the differences between melanoma and this. But for a trained eye, it is very obvious that you're not looking at a melanoma.
Yeah.
And because melanoma is part of a sphere, its configuration is always dome shaped, unless of course it's broken through the Brooks membrane, then there is a nodule on top, which will look like a mushroom. But here the configuration is very irregular, and polyps and bilaterality, multifocality, all these are suggestive of, and block fluorescence on FFA, all this is suggestive of this entity. This is a very rare one, but of course, I'm sure most of you will be seeing it, and sometimes it's difficult to recognize.
We are seeing more and more. I think more that you look for it, I think we see it more often. Also, these are referred. I think they would be referred to you also because of the DD of melanoma.
Yes.
Dr. Dairis, exudative detachment and say subretinal hemorrhages. For exudative, you may be giving an anti-VEGF and after identifying this as a PHCR. But in case there is a subretinal bleed, which is massive in nature sometimes, which can be seen with this. So do you give a TPA along with that?
Yeah, I think that's a good option. If there's a massive subretinal heme, because the cases I showed, the vision was down, but the heme was very thin. So that did well with only anti-VEGF. But it is massive, then we have to do it. And in fact, I just recently operated a patient with massive subretinal heme, but it was just below the fovea. So I was wondering whether to cut the retina and reflect, but I didn't. I just gave an anti-VEGF in the eye at the end of the surgery, and that did well. But if that sort of heme is encroaching the fovea, then a TPA, a gas plus anti-VEGF, it'd be triple therapy. Put a gas bubble, inject TPA and gas, and then position the patient with the prone positioning to kind of move that blood out of the foveal area.
Yeah, can thermal laser be an option in where the leakage has still not happened and you have been able to identify it before?
The challenge of thermal laser is basically when these raised lesions are there with a lot of exudation, your laser uptake is not great. So earlier people used to do a lot of cryo, but the regimen I follow is maybe give a few anti-VEGF injections, which reduces the exudation, and then it is more amenable to kind of have the uptake of the focal laser. So yeah, I think thermal laser is not a bad idea because there's nothing to lose by doing a destructive procedure in such peripheral areas. There's nothing to lose, and what is to gain is that you may decrease the frequency of injection of the patient having a huge subretinal heme or a vitreous hemorrhage. So I think it's a good idea to do combo therapy. Reduce the exudation, make it amenable to, like, you debulk a tumor, like so to say, but I mean with anti-VEGF, make it less exudative and then target the areas which are leaking.
So just to add, any experience with PDT in such situations?
No, personally, I've not done PDT because I found it, PDT generally I reserve for lesions like hemangiomas and all which are subfoveal or encroaching on the fovea. So generally, the lesions I've seen are a little away. I don't know if Dr. Honavar has seen any which required PDT.
No, they're generally away, so they don't encroach. And then there was one accidental case which I recall having been presented in one of the oncology meetings where the patient presented with HCR unilaterally, and oncologists also thought it could be an unusual form of diffuse melanoma, so they did brachytherapy. And it resolved beautifully. And the patient developed a similar lesion in the other eye. Then that was a smaller lesion, and retrospectively they diagnosed it. So there's a case for brachytherapy, but of course there's just one incidental case. You can't really say that it is going to work. But in that case, there was a beautiful resolution.
How does it work exactly? How would brachy work in such a?
It might be working on the choroidal vasculature, because even in ARMD now there is a new implant which Paul Finger has developed where they go behind the eye and irradiate it, translated radiation, which is a handheld radiation device. So it must be doing something to the vasculature.
And that goes along with our theory of showing the choroid is thick in that area, that pachychoroid spectrum. So it's nice, very nice points.
Right. Dr. Nagesha, any comments on?
No, I have two questions to the Dairis, sir. In the first case, you have told you have done a focal laser based on the FFA leakage. I was just wondering what was the leakage in FFA in that area, and what exactly you were targeting there. And the second question following is, you have noted polypoidal lesions over a period of time when you got to the wide field imaging. So now the terminology about the PHCR and the peripheral PCVs are kind of, people are looking back, whether these are all peripheral PCVs. There's nothing a new terminology like a PHCR. What is your experience about it? How frequently you saw the polyps after resolution of the hemorrhage with the wide field ICG and all those things? Can we just call all these lesions as just a peripheral PCV, a kind of variant of normal macular PCVs? Because I've seen a couple of patients who had this combined macular PCV and the peripheral PCV, where they have no swelling at the macula with the hemorrhage, and peripherally they have mold as well. Just wanted to have a comment from
polyps are not a constant feature. That is the problem. Here, polyps are not a constant. Even after the lesion regresses over a period of time, you don't see residual polyps at all. They are there, but they're not a constant feature. That is possibly, there is a possible association, but it is not constant. So there is a merging of term between peripheral polyps, and that is happening, but we have really not understood it to that extent that we can say these are the same.
Okay.
There's a publication from Bascom Palmer in Retina which says that PHCR, there are two subtypes of PHCR. One is because of a peripheral CNV and one is because of peripheral polyps. So that it is like a spectrum of diseases. So like Sir said, we don't always find polyps, but in the cases where we found the choroid thickening, which we had the 16 mm scans for, I think there were about 25 eyes or something in that publication. I think a majority of them, maybe 75%, we did find polyps on wide field ICG, because by that time we had this imaging modality. So I suspect that polyps are there, but they are either masked, they're hidden. You have to look for them in a very peripheral location, and they may be under blood and exudation. So that's so. And as far as laser is concerned, the first question is once you debulk it or you make it less kind of exudative, wherever you find kind of leakage areas, I think there's no harm in just lasering them off. I mean, I just put on a LIO and laser. It just takes a little time. And I know it's not such a very elegant way of doing it, because you're kind of, you don't have exact areas to do it, but wherever you feel it's kind of a leakage or a peripheral CNV, you can laser it off. I mean, in the past, they used to even laser CNVs in the macula, if you think of a history. Of course, they never think of that now, but if there's no harm doing something, laser to something so much in the periphery at all.
Okay. And I have seen those patients who are on blood thinners. So they get this kind of bleedings, vitreous bleeding, even if you small anti-VEGF injection. Though we had a 6/6 vision, next day come with the hand movements. It was so uncomfortable situation to explain why there is a vitreous bleed and all. You have anything noted, like those who are on blood thinners are more prone for breakthrough hemorrhages in this kind of cases? I mean, including the PCV and the peripheral PCV, what are the PSCR and also?
Yeah, I think a lot of people ask me this, but no, I don't have. I don't have any experience, and I'm not even sure whether it's related. But it is something which is definitely has been kind of highlighted in the past. But I don't have an answer for that. I'm not sure about this.
Thank you.
Right. I think we can move on to the next and the last presentation by Dr. Diksha Katoch. She's an associate professor at Advanced Eye Center, PGIM at Chandigarh. She'll be talking on a very important topic of anti-VEGFs in retinopathy of prematurity.
Thank you. At the outset, I would like to thank AIOS, and I'll just share my screen. Is it visible?
Yeah, Dr. Diksha.
Yeah, so I think I'll just deviate from the topic, and in the interest of time, also try to wind up a little early. So the topic here I chose to present was anti-VEGF in ROP, because I think this is a topic that is burning in the context of retinopathy of prematurity and also in our country. So just to begin, just to introduce that why this is important, because India has the highest number of preterm births globally. And I do not know whether you all have read, but now preemies as young as 22 weeks of gestation and even less than 500 grams are surviving in our country, thanks to the improvements of the neonatal care. But it is going to add on to the burden of ROP screening and treatment in our country. And as per a little late estimate, around 190,000 neonates are at risk of developing ROP. And considering that even if only 10%, that this is a little lesser risk, 10% require treatment, more than 20,000 infants will be requiring treatment every year. And not only extreme preterms, even the heavier birth weights and more mature infants in our country develop ROP. And that is why the screening guidelines in our country are a little more wide to include all infants to be screened up to a birth weight of 2,000 grams and up to 34 weeks of gestation, and even heavier, up to 34 to 36 weeks of gestation, if there are any of the risk factors. In fact, any history of admission to a neonatal ICU or an SNCU can also be taken as a surrogate risk factor and to be screened for ROP. And we all know that the first screening has to be done within 4 weeks of life, and infants who are less than 28 weeks and less than 1,200 grams need to be screened within 2 to 3 weeks postnatal age. It is important that the first screening should be done at least once before discharge. In our NORS center, we are seeing an increase in the number of infants that require screening, also an increase in the number of infants require treatment. In 2017, we treated annually around 132. Now we complete this number in the first 4 to 5 months of the year. So it's almost like doubled the number of treatments. So we are in the midst of an epidemic of ROP, and there are several factors. But as ophthalmologists, we need to know that there are lack of trained ophthalmologists who are into ROP screening and treatment. And it is important that we need to create awareness amongst ourselves about this disease. Just to brief that in the left panel, we see this is the RETCAM photograph of an infant who does not have ROP. And we see that the normal vessels, the retinal vessels, how they branch dichotomously. And but around 40 weeks of gestational age, they will reach the ora serrata, which I've highlighted in the arrow. Now, in the event of a preterm birth, there will be variable degree of avascularity and immaturity. And at the junction of the vascular avascular retina, you will start seeing the stages of ROP, which typically pass from stage 1, which is the demarcation line, to the ridge, to stage 3 with extraretinal proliferation seen as 1B, to 4A retinal detachment, 4B involving the macula, and then stage 5. In the recent classification, stage 5 has been further classified in bedside classification, where if the optic disc is visible, it is stage 5A. If the optic disc is not visible, it is 5B. And if it is accompanied by anterior segment changes such as shallowing of the anterior chamber, posterior synechiae, it is stage 5C. And then we have another subgroup, which is aggressive ROP. Earlier, it was called aggressive posterior ROP, where this disease does not pass through the typical stages. And we need to recognize its features because there is a high risk of progression without timely treatment. So what are the indications of treatment? For years, we have known from the ETROP study that type 1 ROP, which is zone 1, any stage with plus disease needs to be treated, and zone 1, stage 3, even without plus needs to be treated, and zone 2, stage 2 or 3 with plus disease needs to be treated. Just to let you know that there has been an addition in the zones, the typical from 1, 2, 3, we also have an additional posterior zone 2, which seems to behave a little more aggressively than the anterior zone 2 disease. However, it still has better outcomes than zone 1 disease. And also we need to treat any aggressive ROP. And rest of it, which is the typical type 2 ROP, needs to be followed. The management of ROP actually involves a lot of concepts, and it starts with doing a timely screening and a proper referral. And after that, obviously we have laser photocoagulation, which is still considered the standard of care. But we have an additional anti-VEGF therapy, which is now being used increasingly. Also, we have options of surgery. The outcomes of surgery have improved in the MIVS area, but there is also the management of long-term sequelae, which also forms a major chunk for long-term follow-up and comes in the domain of a lot of general ophthalmologists as well as comprehensive ophthalmologists. Before I go on to anti-VEGF therapy, let me just brief you about our own experience about laser. And for most cases, like for high-risk pre-threshold ROP, the outcomes are nearly 100%. And no matter what the trials tell you, your own experience does count. So this is, and even for threshold ROP, the favorable outcomes with laser photocoagulation are more than 90%. Only in selected cases of aggressive ROP or aggressive posterior ROP is when the outcomes of laser photocoagulation as a standalone therapy tend to go down. So what we should not forget what our own experience in managing these cases is. Now, coming on to anti-VEGF therapy, it is the most recent advancement. It is now considered an alternative or adjunct to laser photocoagulation. There are several advantages to it. like the ease of administration, being a shorter procedure, not requiring any fancy equipment like the LIO, and leading to a rapid resolution of the acute phase ROP. But what actually the benefit really is not these, but it is the potential to allow normal retinal vascularization to progress, improve outcomes in posterior disease, and its usefulness in sick infants who probably will not be able to undergo the procedure of laser photocoagulation, which is a longer procedure. So these are the important practical advantages of anti-VEGF therapy. We have bevacizumab, ranibizumab, and aflibercept, which are available and which we commonly use. Regarding the dosages, though for bevacizumab, several dosages have been described, and even doses as low as 0.0004 milligram have been reported to be efficacious. However, for most practical purposes, most of the ophthalmologists who are managing ROP still remain close to half the adult dose, and it will be somewhere between 0.5 to 0.625 milligrams for Avastin. For ranibizumab, it will be around 0.2 milligrams. For aflibercept, either 0.4 milligram, which has been reported in the Firefly study, or half of the adult dose are the ones that are more commonly used. What is the protocol for the injection? It can be injected either in the NICU or in a sterile OR environment. All the injections can be done under topical anesthesia. Usually, though there are several reports of giving unilateral and debate about unilateral versus bilateral injections, considering the time that is there and the need for, keeping the baby for a day, having another injection, most of the ophthalmologists who are treating anti-VEGF tend to do it bilaterally in the same sitting. It is important that we use comfort strategies of swaddling the baby, using a pacifier or oral sucrose to allow the compliance to increase with the anti-VEGF therapy. Ruling out active infection in the form of conjunctivitis or an active NLD obstruction, and using the standard sterile precautions which we use routinely for other anti-VEGF injections. Usually a shorter needle either is used. You can use a 30 gauge or a 32 gauge, and if it's available, a 4 millimeter needle should be preferred. It is very important that we give betadine before and after the injection. And the technique of the injection that we have to remain 0.75 to 1 millimeters posterior to the limbus, and the direction of the needle should remain parallel to the visual axis rather than towards the center of the vitreous cavity, where we can inject directly into the lens in these small children. How do you follow up? The first follow-up has to be within 24 to 48 hours after the injection, and then at 1 week, and thereafter it has to be 1 to 2 weekly till, well, the question remains till when is still a big debate. However, we need to see till either mature vascularization is complete, or like I'll tell you in the following cases, that at least up to 55 to 60 weeks of post-menstrual age, or in our own setup, we have to see that with how comfortable we are in doing a second treatment. Maybe we need to retreat earlier. In that situation, we may require a retreatment by 50 to 55 weeks. The second treatment, we need to see whether we can do it comfortably under topical anesthesia, or requirement of general anesthesia is there, whether the parents are available for regular follow-up. So all these questions have to be answered before we decide when to do a retreatment. The complications include of cataracts, and the most dreaded is endophthalmitis, though the overall risk of endophthalmitis following anti-VEGF injections in these neonates is low, but still, nevertheless, we have to be aware of this. How do you select an infant for anti-VEGF therapy? Which cases to choose? So the first and foremost is the location of the ROP. So anti-VEGF therapy should be restricted to cases either in zone 1 or posterior zone 1, or cases of aggressive ROP. So this is a representative case of aggressive ROP. Here we see, I'm just put up the angiogram just to show how it appears on the angiogram. However, most of the diagnosis is clinical and can be made out. We see that there is loss of the dichotomous branching pattern. We see these shunts, and we see dilatation and tortuosity. And we see that there is a large avascular area, almost up to reaching up to about a disc diameter temporally. And we also see that there is neovascularization of the disc. So these are the garden variety of cases where we should consider anti-VEGF therapy as first line. Second would be cases with very severe tunica vasculosa lentis, which is not allowing adequate pupillary dilatation to perform laser photocoagulation. Most of these cases, if you see, which have such severe TVL, will also have a disease which is lurking like this behind, where you have very severe plus disease also behind, and you have an aggressive ROP-like features. We have flat neovascularization. So the previous case was a posterior zone 1, like we saw that the vascularization was not even crossing the fovea. This is posterior zone 1 aggressive ROP, and this is anterior zone 1 aggressive ROP. So this is the response that we get after anti-VEGF therapy. There is a very, very rapid response, very rapid reduction of the tunica vasculosa lentis. This is another case of a posterior zone 1 aggressive ROP, and we see the response after anti-VEGF therapy. Now here we have 3 cases, A, B, and C. The A case is the zone 1 anterior aggressive ROP, but if we see the B case, in the B case, if you compare the vascularization close to the optic disc, and we see the differences between A and B. So relatively more mature vasculature, there are few dichotomously branching vessels, and we see a white ridge with extraretinal proliferation that is in zone 2. Now, in these cases, you may choose to do an anti-VEGF, but our experience shows that these cases respond very well to a single session of laser photocoagulation, with the added advantage that you may reduce the follow-ups. And also it has been shown that cases in zone 2 ROP do not induce, there is not much induced myopia after laser photocoagulation. So for zone 2 disease, I would still recommend laser photocoagulation as the first line of therapy. Now this is another case, the C case. Here we see this was again referred for treatment, but if you look at what the pattern of vasculature is, even close to the disc, we see that there are no loops, no shunts. In fact, there is no evidence of plus disease. There is some mild tortuosity close to the junction of the vascular avascular retina. There is an ill-defined ridge at places. This is what is known as hybrid ROP, where you have few features which resemble aggressive ROP in the early phase, and there is a ridge which is not a continuous or it is a discontinuous ridge. Now, this case should be followed up closely. In this situation, you can rule out other systemic factors such as anemia or any infection, and also see whether the child is gaining weight, because some of these type of diseases will either progress to a staged ROP or may also show spontaneous regression. But this definitely at this point of time does not require any treatment, needs a close follow-up. Here again, we have cases of a notch. This is also described in the new ICROP classification. We have a posterior incursion of the posterior of the avascular retina in a more posterior zone. However, these cases tend to behave in a way like where the majority of the avascularity would be. So this would typically behave like a zone 2 disease. And this would also do very well with laser photocoagulation again. In fact, both these cases will do very well with laser photocoagulation and should be offered first. Here is another case which has been referred for treatment. And if here we see in the right eye, where the blue arrows show, there is some vascular shunting, but there is no plus disease, there is no arteriolar tortuosity, not much dilatation. In the left eye, there is a posterior incursion of the avascular retina. There is a ridge which is ill-defined but is entering into zone 1, and there are few popcorn lesions. Now this, the parent of this child had been clearly told that the child needs to be treated. And it was very difficult for me to convince that I would like to follow up this child for some time, because at this time, to my mind, this child did not require treatment. So after ruling out other parameters like checking the hemoglobin and the systemic features, I tried to convince him after showing the photographs that we would like to follow, and if you can come, we would like to wait for now and see how it responded. The avascular retina slowly vascularized completely, and this child did not require any treatment. So recognizing the feature, not all type of ROP is going to require treatment. So we need to look into the features carefully. So this retina completely vascularized without any treatment. The problem with anti-VEGF therapy that we have to, if we inject, we need to be aware of the reactivations. All of the anti-VEGFs will tend to reactivate. The reactivation rates are higher with ranibizumab up to 83%. And the timing of the reactivation also tends to come earlier with ranibizumab. So which injection we are giving, we should be aware of the average time that this disease is likely to recur. Most recurrences occur within 37 to 60 weeks of postmenstrual age, and that is why the arbitrary time limit of follow-up of following these infants with the anti-VEGF monotherapy at least up to 60-65 weeks of gestational age, because that is the time where most of the recurrences will occur. However, recurrences can occur even later, even up to 2 to 4 years they have been reported. And so that if you are giving only anti-VEGF monotherapy, that counseling has to be done to the parents of the infant. Recurrences have been reported with bevacizumab up to 18.3%, and infants who are lower gestational age tend to be at higher risk. They have been reported with ranibizumab, even higher, even with aflibercept. I'll just give you a little quick case about recurrences. So this is a child with posterior zone 1. This is how it was 5 weeks after Eylea, 9 weeks, and this is 16 weeks after Eylea. Now, clinically, this may not be very apparent. However, there is a faint ridge which is developing at the vascular-avascular junction. But if you do the angiogram, you clearly see that there is a lot of avascularity, what is known as the persistent peripheral avascular retina. We see new vascularization at the junction and treatment. The benefit also from anti-VEGF is clearly shown in this angiogram from the blue arrow to where the vascularity has reached in the left eye as well as in the right eye. So this will require a retreatment, and in most of these situations we do a repeat laser photocoagulation. So ICROP3 now includes a definition of reactivation. And these are other examples of persistent peripheral avascular retina after anti-VEGF monotherapy. Now, how do you treat a reactivation? This is also an ongoing debate. What would you do? Whether you will do a repeat laser or a repeat anti-VEGF. People have described giving up to 2 repeat anti-VEGF injections. However, I would like to show my experience of a repeat injection. And after that experience, my treatment for a reactivation is laser and laser photocoagulation alone. So this is one child with zone 1 aggressive ROP after 2 weeks ranibizumab. This is 5 weeks after the first injection. You can see that the disease has reactivated at anterior zone 1. And there is a ridge which has developed at the vascular-avascular junction. At this time, we did give a second injection. This baby is now 9 months old. If you clinically, this may be not very apparent whether there is a persistent peripheral avascular retina, but if you do an angiogram, you see there is a significant amount of persistent peripheral avascular retina. There is new vascularization at the junction, and this child, after the second injection, we did laser photocoagulation. Noteworthy is that the retinoscopy at 6 months, when not even a single spot of laser was given, the child was already myopic. So the myopia is directly related to the severity of the disease. So if the more posterior the location of the disease, the more likelihood there is a chance of myopia. This is another case example. And this is again a zone 1 disease. This is 1 month after second injection. This is after the second angiogram, after the second injection, and we see that disease is very much active. There is a lot of leakage. This again was treated with laser photocoagulation. This is another example after second injection when there was a recurrence with presence of hemorrhages, again treated with laser photocoagulation. We also need to remember that there is a possible risk of going into a crunch phenomena with repeated anti-VEGF injections. So in this situation where you have a child who's been treated with anti-VEGF, even laser, and you think that a second anti-VEGF may help, no. First, we need to assess whether the laser is complete. If there are any areas which are left, which are still avascular, those have to be filled up. And if you need to give a second injection, please counsel the patient that there is a risk of that the child may require a surgery in case of there is a crunch. And you should not inject unless you have facilities for managing the crunch phenomena available with you. And this is also one last case of a second injection and a recurrence after a second injection. So my take-home message is simply that first, the ROP screening needs to be done not only for very preterms, but also in optimal gestational age infants with risk factors in our country. Laser therapy is still the standard of care for most cases of ROP. Anti-VEGF therapy is emerging as a potential alternative as first line to laser in zone 1, posterior zone 1, and aggressive ROP eyes. However, they do require longer and more frequent follow-ups. Late recurrences are possible, and in which situation mostly we will require to do a laser therapy for the persistent avascular retina, and the decision for a repeat injection should be considered only after very careful clinical assessment. Thank you.
Thank you, Dr. Diksha, for touching upon a very burning topic, which actually is something which we see quite often now because of the lower weight babies. I have personally treated 650-gram baby, and child is doing well now after 2 injections of anti-VEGF and a little bit of laser. So it's quite common that we see that now in our practice. So the important points, if you have to highlight, Dr. Diksha, one, where to give. Say there is a debate where we would like to inject, say 0.75, 1, 1.5. So the average is 0.75 to 1. So you can go up to 1, even you can go up to 1.5, but the mean thing is you should go at around 1 millimeters. If you go very close, there is a danger of injecting directly into the lens. So 1 millimeter is a relatively safe zone. So 1 millimeter I would recommend going at 1 millimeter for the injection. Right, ma'am. So while injecting the anti-VEGF, do you take any special precautions? And says you said it can be done in NICU or in OR. So while injecting, do you anesthetize the baby? One. Second, you hold the baby and just put a topical paracaine and give an injection. So all the injections are done under topical anesthesia, whether you do them in the OR or in the bedside. You have to follow all the precautions that you are doing for other anti-VEGF agents. So you need to scrub, you need to use clean, sterile instruments. If you swaddle the baby nicely, means his hands and legs are not moving about, then the cooperation for the injection, the movement during the injection goes down. So if the baby is swaddled up nicely, it will be more safer to inject with lesser movement. Also, if you give a pacifier like an oral sucrose suck, again, that will help in reducing the movement of the baby while you are injecting. And so when we are injecting, we use 2 separate set of instruments, like 2 speculums, 2 markers, 2 injections, and then we give the injection. And the use of the betadine is a must and has to be done after you put the topical proparacaine, and after some time you put the betadine, then you inject. And then at the end of the injection, again, we put in betadine drops. And we do give topical antibiotics a day prior and to be continued 3 to 4 days after the injection. Practicing at a tertiary center like PGI Chandigarh, which anti-VEGF is your choice? Bevacizumab, ranibizumab, or aflibercept? Now, most of the, just I said that we now know that the recurrence rates of with ranibizumab are higher as compared to bevacizumab. So a lot of practitioners are using Avastin, but in our practice, because we are in a government setup and we have government sponsored programs that are ongoing, like we have the JSSK program, wherein the injection is given free of cost to our patients. In the government supply, because razumab or the ranibizumab has been approved by DCGI, that is what is available to us. And for all our patients, we are practically injecting ranibizumab. Right. Do you ever recommend a child with a stage 2 ROP, zone 2, stage 2 with plus disease, given a trial of anti-VEGF followed by laser? No, I wouldn't do that. Though you highlighted not to. I wouldn't do that because I know that stage 2, zone 2 ROP is going to respond beautifully to a single session of laser, and then you are done with it, and you don't need so frequent follow-up. But if I will give an anti-VEGF
And then I will have to keep on following up, and the child will grow up. Then I will have to decide when to do a laser or when to take up for an EUA, and whether I will be able to comfortably do a laser in topical anesthesia versus general anesthesia. So that debate I will only do for a posterior ROP, not for stage 2, zone 2 ROP.
Right. I would like to get a comment of Dr. Darius Shroff regarding
Yeah,
his
I had a
experience.
question. Diksha, excellent talk. I couldn't understand why was there so much difference in the recurrence rate? And actually, if you see the slide, Macugen seemed to be working the best. So what is the actual reason, just out of interest?
No, this
difference
is
in
because of the
anti-VEGF?
VEGF molecule itself.
Okay.
Ranibizumab, we know, has a shorter half-life. So the duration of action is shorter for ranibizumab compared to bevacizumab, which are larger molecules. So even in adults, the serum half-life and the vitreous half-life of bevacizumab is higher than ranibizumab. So for this, the same thing applies in infants.
So if you had a choice, which molecule would you use?
See, if it had been approved, then bevacizumab is better.
Okay.
But we don't have it in our center. So we are giving ranibizumab for children who can, for parents who are willing and afford. Even aflibercept is working very well, and the recurrence rates are almost comparable to bevacizumab, obviously, but it is a costlier drug. So again, those whether parents are able to afford it or not, all those issues come up.
Okay. But the quantity which you get in the vial of aflibercept is higher, so you could use one for both the eyes.
Yeah, usually we do with one eye, we give one vial, we give both the injections.
Okay. Thanks.
Right. Dr. Darius, your experience on ROP?
So I don't do too much ROP now, but I think the most important message for everyone hearing this is that you please, even after anti-VEGF, the laser is most important, because like Dr. Diksha says, if we don't do laser, there's no endpoint. We don't know how long to follow up. And also remember, doing laser, the bigger the baby gets, the more difficult to treat at that stage. And then you need general anesthesia, etc. So I think what I follow is that we give anti-VEGF, let the vessels grow out further, and then do laser. Sometimes I'd even do a combo therapy. The first sitting, give anti-VEGF and a little bit of peripheral laser, let the vessels grow out a little more, and then add a little more laser. I don't know whether you have any thoughts on that.
Just like in DME, where the trend is to give anti-VEGF and defer laser to as much as possible. So similar trend is there in ROP management, where if you have considered anti-VEGF as your first line therapy, then and the disease has responded to your initial treatment, then you will like to defer laser, defer as much as it is safe in your hands. So defer if you can follow up, parents are willing to come, defer till you have a reactivation, where at that point I will do a laser. But again, and you have facilities for, treating bigger babies, possibly under general anesthesia. If not, then maybe you have to take that decision a little earlier, where you can, safely treat under topical anesthesia. So roughly, if the child is around 3 kgs, up to 3 kgs, you can still treat under topical anesthesia. But if the child goes above 3 kgs, then it is a little difficult to manage a struggling child, and then you have to do a complete justification to your laser treatment.
Thank you.
Yeah, ma'am, how will you identify, say, vascular arrest, and when will you decide that vascular arrest has happened and it's time for me to do laser?
And that's what I was saying, that vascular arrest, so some of the photographs that you saw of a zone 1 ROP, you had closed loops that were there, and the change that happened after your anti-VEGF. So the loops opened up, your plus decreased, and you saw a progression of vascularization. So if you do a good clinical examination, you can see up to what zone your vessels are growing, and then there is going to be a abrupt cutoff, that beyond which the vessels will not be seen, and you will see an avascular retina. Now, if it is in a more posterior zone, for example, zone 1 anterior, posterior zone 2, it is easy to identify clinically. But if it is more anteriorly, then at that time, you may require depression, or you may require the child to be taken up under general anesthesia. But the identification is an abrupt cutoff of the vessels between the vascular and the avascular zone. At that point, whenever there is a reactivation, you might see a white fleshy ridge-like thing, which is not the typical ridge which you see in a staged ROP, but it is a little more fleshy, much more flatter and widespread ridge that is coming up at the vascular-avascular junction. And if you are serially following up, you will see that there is some return of the tortuosity. Though there may not be dilatation, but a return of the tortuosity from your previous follow-ups is an indicator that possibly the disease is beginning to come back, and that is the time you start counseling the parents and prepare for your second treatment.
When will you give your ma'am second anti-VEGF? After how long the duration gap between two anti-VEGFs?
But the gap between two is that you don't give a second injection before 4 weeks. So not before 4 weeks.
Right. So will you go ahead with the second injection at 4 week exact, or you will like to have a clinical examination and determine based on that whether I need to give it or not?
Obviously,
there is a growth and things are improving.
Obviously, for any second treatment, whatever you want to do, after my experience with the second injections, I have stopped giving a second injection. So my second treatment is a laser photocoagulation, and I do it whenever there is a reactivation, at the time where there is a reactivation. So I will wait till the disease just starts coming back, and that time I will do. So I will allow vascularization to go as much into the periphery as possible.
Yeah, Dr. Divya, Alex, and Dr. Hiteshi Jain, any points that you would like to ask? You're not audible, Divya. Divya, you're not audible.
In ROP, I have never given a second injection. What we do is we have plenty of bevacizumab available. So we give a bevacizumab for SON1, and we will allow the blood vessel to grow. So with bevacizumab, it's not like ranibizumab, just like ma'am said. You can allow the blood vessel to grow up to 6 or 7 weeks. So by that time, it would have grown up to SON2 or SON3 edge. So by that time, you can easily give off laser. And I personally don't prefer giving a second dose of anti-VEGF after 37 weeks.
Yeah. I think most of the questions have been very well covered, and probably must have solved most of the queries for all of the ophthalmologists and retina specialists practicing across India. So at this point, I would like to end this very nice CME on walk-in retina patients. I would like to thank Allergan for sponsoring this event and AIOS for organizing this topic of very common, as well as few of the out of order patients as well. Thank you, Dr. Hiteshi Shah, Dr. Divya Alex, Dr. C.K. Nagesha, Dr. Dairesh Shroff, and Dr. Diksha Katoch for gracing the occasion and teaching us about the different aspects of varied presentations in retina. I would also like to thank our chairman, Harbansh Lal sir, Santosh Munawar sir, and Manoj Mathur sir for being there. Also like to thank Dr. Lalit Verma sir and Srinivas Joshi sir for their expert comments. Thank you, everyone.